Thank you for joining us. My name is Craig Spencer. I am an associate professor at the Brown School of Public Health. I work in the emergency room here, and I am also a faculty fellow at the Watson School. I am really excited to give an introduction for our own Dean Baudouin and Dr. Nishtar, who's going to be joining us shortly from Gavi. But first, I want to give a brief overview about the lecture that we're here today, the Barnes Lecture. This is the 27th annual Barnes Lecture, started under the leadership of Vince Moore back in 2000, and has now survived multiple deans, including Fox Whittle, Bess Marcus, Ashish Jha, and now Dr. Francesca. This is named for Dr. Barnes, who came to Brown in 1962 and was really excited about leading a medical program within a liberal arts college. And he created a course that was apparently wildly popular, called The Informative Way of Life, and one of his students, Jim Zisson, endowed this the lectureship in memory of his parents because he viewed Dr. Barnes as a quintessential physician scholar. Mr. Zisson graduated from Brown with honors in 1974 and then led a very successful life as a general manager of A&M Records, co-founded the Palm Health Care Foundation, an entrepreneur, investment manager, and many other pursuits. Mr. Zisson passed away last year. He was a regular fixture at this event in years before, and we miss his presence, but are grateful that his commitment to public health will carry on because of his generosity. On behalf of Brown University and the SPH community, I'm happy to extend a warm welcome to Dr. Barnes' family today. I want to next thank Dean Baudouin, whom I expect most everyone in this room knows very well. A familiar face and another emergency physician, here for 2 decades as a doctoral student, faculty member, department chair, academic dean, and now as the interim dean of the School of Public Health. An accomplished physician scientist and a public health leader, she is a national expert in addressing opioid use disorders and pain management, and really revolutionized serving patients on a mobile drug recovery unit here in one of the most impacted communities in Rhode Island. I want to talk about Dr. Nishtar in just a moment, but I just want to make sure we all understand how impactful Gavi, what we're here to talk about today, has been. Gavi has been around since the year 2000. I teach a class on global public health interventions. I talk about the value and the importance of vaccines and how many lives have been saved in the history of vaccines, but also since Gavi has been around. We're talking about more than 20 million future deaths have been averted because of the work that Gavi has done in the last quarter of a century. Gavi plays a huge role in improving global health security by supporting health systems and also funding stockpiles for things like cholera, meningococcal, yellow fever vaccines, and an important one to myself, Ebola vaccines. Appointed by the board in January 2024, Dr. Sania Nishtar is the CEO of Gavi, the Vaccine Alliance. And before taking on the CEO role, Dr. Nishtar was a senator in her home country of Pakistan and started her career as a cardiologist, as I learned today at lunch. A trained physician, she has built an outstanding career over 30 years as a national and global leader. In Pakistan's national government, she served between 2018 and 2022 as special assistant to the Prime Minister on social protection and poverty alleviation, and founded a social protection program and chaired the Council on Poverty Alleviation and the Benazir Income Support Program. She's also served as a federal minister for reestablishing the country's Ministry of Health and many other roles. And we are so fortunate to have Dr. Nishtar in the role as CEO at Gavi at such a critically important time for the organization and for vaccines. And we are so fortunate to have her here today in conversation with our own Dean Baudouin. So to get the program started, please join me in a very warm welcome for both Dean Baudouin and Dr. Nishtar.
Craig, thank you for those really kind opening remarks. And as Craig said, this is an endowed lecture series. And again, just want to thank 2 families with deep connections to Brown, the Zisson family and the Barnes family. Susan, Andy, and Sarah from the Barnes family are actually Zooming in and watching the live stream. So that's really cool. This event is always a really fun one for us. It is always held during National Public Health Week and is a chance for us to hear directly from the voices that are so critical in public health leadership. And boy, do we have a treat today. So Dr. Nishtar is quite a powerhouse. I can say that about you. I feel very confident saying you're a powerhouse. But I know that our audience would love to learn a little bit more about you. You've been a physician, an advocate, a political leader, and now head of an international organization that has vaccinated, I think, a billion with a B, children, a billion lives. That's quite impressive. But take us back to the origin story. How did you get into medicine and public health? And how does that factor into the work that you're doing today?
Well, good afternoon. And first of all, allow me to thank you for your hospitality, your welcome, your warmth. I really feel very honored to be here and really humbled with your affection. Thank you so much. How did I get into medicine? It's a long story. I was born in a city called Peshawar, which is on the Afghan border in Pakistan. And as a child, I had no interest in studies. I could swim before I could walk, and I played very good golf when I was 8 years old. And then my father died when I was 15 years old. And that was a turning point in my life. I decided I wanted to be very serious with my studies. And that's what took me to medicine. And then I trained to be a cardiologist. And then there was and of course, when you're a cardiologist, in your naivety, you think you're God personified because you zap people, back to life, and in the coronary care units and in the emergency rooms, and you feel you're extremely important. That's how I felt. But the real world is very different. And then there was this one incident that really changed the course of my career. I was doing an angiography in the cath lab, and there was a hospital circular which said we could not use new disposable catheters for poor patients anymore. And I remember that was my last day in the hospital. I said, I cannot spend the rest of my life doing that. I've got to find a solution, an equitable solution for these poor people that need my help. And that decision to take down my lead gown that day has brought me here. And it has really taught me a lot. It was a very acute learning curve for me. I decided to set up a foundation, and in those days I knew nothing about institution building, nothing at all. I was just a cardiologist with standard cardiology skills. So I founded an organization. I took it to scale. That was my exposure to public health. Then I went back and did a Ph.D. And subsequent to that, I got introduced to the world of policy advocacy, continued with that course in my own country, then got networked with the international community. Then I was invited to join the government once. Subsequent to that, I chaired a couple of commissions for the World Health Organization. And then I was asked to join the government again. And then I served as the Minister of Social Protection for several years. Then finally got into politics and was a senator. And then this opportunity came. So that decision in the cath lab that day took me from bedsides to boardrooms, from hospital beds to founding institutions. It's been a long journey, and I've learned a lot along the way.
That's amazing. I mean, very powerful story. We have a lot of students in the room, and I know that will resonate with them. I mean, many of us in this room started our journeys, not obviously quite in that way, but thank you for sharing that. I'd love for you to talk a little bit more about the work that you did in Pakistan. I mean, we talked about this a little at lunch, but it'd be great for the audience to hear. You worked in a complicated and complex environment, and I think that resonates with many of us today. How were you so effective in pushing forward health reforms in what I think many would perceive to be challenging, to say the least?
So in Pakistan, I worked in different capacities. I was I was a physician there. I was a civil society activist there. I was an advocate. I was a parliamentarian, and then of course I was a cabinet minister. And it was an enormous privilege to be able to serve people in my country. When I was the Minister of Social Protection, we increased the number of people receiving social protection benefits from 5 million to 15 million. It was an enormous jump, and a huge ecosystem of welfare was established under a program called Ehsaas, which means compassion. And there were some very important learnings in deploying that program at scale. And of course, I had to navigate a very difficult environment, because when you want to deploy things at scale, at speed, and you want to do things in a rule-based manner, in an evidence-based manner, it is hard. And especially for a woman to do that is even more difficult. But I'm humbled that I was able to achieve what I set out to do, thanks to the support of many colleagues. But it was difficult.
We'll talk about Gavi in a second, but how are you bringing some of that skill set to your work today? And how can those of us that are trying to navigate various public health systems and implement change, what are some lessons that we could all draw on?
Yeah, so one of the lessons that I learned from my political life back in Pakistan was that in order to run large-scale operations, you have to be standing on a solid footing, and you have to make sure that your institutional base is very strong. You have to make sure that you bring in the policy reforms, that you do the digitization, that you do all the boring things that people don't like to do. Bring in policy reforms, fix procurement, pay attention to digitization, make sure that the checks and balances are there. The how-to of reform, institutional reform. So the learnings from Pakistan were very important in bringing those changes at Gavi, and that's the first lesson I learned.
Were you really hands-on in those? How in the weeds were you?
Oh, absolutely, yeah. Absolutely. I have a colleague sitting in the audience who will bear me out. You absolutely have to be in the weeds, and at some point you are you risk being called a micromanager, but you really have to fix the institutional base before you aim for large scale delivery. And that's one of the lessons I learned, which is what I deployed. So for me, looking at all those things, the checks and balances, the financial systems, the procurement systems, was the basis of where I started. The other thing that I learned, and which I've applied to my international, to the international institution as well, was that you really have to be rule-based. You really have to be rule and evidence-based, and that's another thing that I brought with me and tried to carry on. Thirdly, you really have to have a clear strategy, and you have to have a team executing that you empower. And of course, I'm blessed with a great team that I rely on a lot. Fourthly, you have to rely on partnerships. You cannot do everything. You have to appreciate what your comparative advantage is and where you will rely on external entities. And then, of course, you have to be absolutely on top of execution. At Gavi, I joined 2 years ago, and at that point, I realized that the environment had changed drastically. The era of the MDGs and the era of the SDGs is practically behind us. And we're looking at a very new environment, essentially at the beginning of end of official development assistance as we've known it for a very long time. In an environment where there's a lot of silver lining against some dark clouds as well. There's this whole movement of country sovereignty in Africa, for instance, where countries are stepping up to be more self-reliant. And in this new environment, I was very conscious that we had to bring in a set of reforms, and that I had to play a part in navigating Gavi to be relevant in a future global health ecosystem. So there was a very heavy-duty agenda of reforms that had to be executed on a very fast pace, with multiple changes cascaded into planning and execution simultaneously. And that requires a lot of execution discipline. Because your question was about how my experience in Pakistan helped me here. I think the work that I did over there with multiple welfare programs executed simultaneously in a complex country of over 250 million people really helped, because I had the appetite to take risks. I had learned how to accept mistakes, which is part and parcel of fast-paced execution, and the ability to course correct in real time as you go along. And that is the ethic and approach that I deployed in Gavi, because initially when I came and I said, we have to change all these things together. And initially, people thought I was being overambitious and that it would not be possible to do that. But 2 years down the line, and I say this with great humility and thanks to the hard work of my colleagues and thanks to the manner in which we were able to work together, we're quite further along in deploying those reforms.
Let's back up a little bit for our audience. Tell us more about, why does Gavi exist, and what do you see its role playing today?
So Gavi basically does two kinds of things. But before I describe those, let me tell you that Gavi is a public-private partnership. It's incorporated in Switzerland. And its mandate is to promote access to vaccination. Its work can be broadly falls in two big buckets. The first big bucket is to provide access to vaccines, and we vaccinate 6 out of 10 children born anywhere in the world. The way we work is quite novel and innovative. We are not a regular UN, we are not a UN agency. As I said, we are a public-private partnership, and we are quite flexible and innovative in the way we work. So we crowdsource the demand for vaccines from many countries, from over 50 countries. Then we work with the commercial sector, with the pharmaceutical sector. We give them advanced market commitments, and we're able to drastically bring down the prices of vaccines, subsequent to which we make those vaccines accessible in countries. And we co-share the cost of those vaccines with countries. So we're not a charity. And countries co-pay for vaccines, and they ultimately transition out of Gavi support. So to date, 18 countries have transitioned out of Gavi support. Countries as large as India and Indonesia that once had Gavi support are now fully paying for their vaccines. So we help introduce, and then countries gradually take over. Today there are 20 vaccines in our portfolio. So that's the one thing that we do. And I'm sure you all know that vaccines is the best public health buy. The other part of what we do is related to global health security, which is relevant to all countries of the world. And we work in the area of global health security by maintaining vaccine stockpiles. So the strategic stockpiles for vaccines like the Ebola vaccine, the yellow fever vaccine, the meningitis vaccine, the cholera vaccine. And very soon we'll start having the Mpox vaccine stockpile as well. And then we've been vested with special capability to mobilize funding quickly during outbreaks and pandemics. We are the custodians of what is called the First Response Fund and the Day Zero Financing Facility. When emergencies and outbreaks and pandemics happen, we have the capability to mobilize funds very quickly. And that's a mandate that some member states on our board have given us. So these are the two things that we do in the space of PPPR, as we call it, pandemic preparedness and response. And then, of course, as of late, we have also tagged another area of work to this bucket, which is to promote supply chain resilience. So we are heavily investing in to promote commercial vaccine manufacturing on the African continent, predicated on the understanding that that is an ask by stakeholders from the continent. So these are the two different buckets of work that Gavi does. We are, as I said, a unique organization. We deliver at a very low cost, at scale. We deliver results. For every dollar invested in Gavi, you get $54 of economic return. We've vaccinated over 1.2 billion children to date, saving over 19 million lives. And of course, the journey continues. We are in our 6th 5-year strategy cycle. And despite the funding cuts that we've had, our ambition has not gone down. Our ambition is to vaccinate another 500 million children, twice as fast as we did before, over the next 5 years. And this will translate into another 7 to 8 million lives saved, and another $100 billion worth of economic benefits further accrue to the society. And what's important is, as I mentioned before, that we don't operate like a charity. Countries co-pay. And I just want to say this for emphasis once again, because this is so unique about Gavi. We are the only international organization, and I say this with great humility, that has a true graduation model. You know, today, in whatever will be the new international development architecture, some characteristics of international agencies are being described. You know, low operating cost, delivery of value for money, capabilities to transition countries. We deliver on all these variables as we speak.
Yeah, this is, I mean, lots of room for optimism. You just described very ambitious efforts that have actually been executed on. Where do you see, I always frame as opportunity, right? Where do you see the opportunity to further move the needle on vaccine equity and as it relates to distribution, or really wherever you want to take this? So there's been a lot of growth and a lot of building. What's the next part?
So when you talk about vaccine equity, of course, you know, there are two parts of what Gavi does. There's a stream of work of Gavi that has to do from the market shaping work that we do with manufacturers to the delivery of vaccine at tarmacs. That's leg one. And then the other leg of our work is from the tarmacs to the arm of the child. And I would say that as far as the first leg is concerned, we do a very good job. But on the second leg, beyond the tarmac, we're dependent on the systems of the countries, you know, to put the vaccines on wheels, to carry it through their logistic systems, to put them in the warehouses, maintain the cold chain, use their health workforce and their health systems to deliver them through their field infrastructure and primary healthcare systems. And that's where there's a lot of variability. There are countries that execute well, and there are others that do not. And which is why we are now, excuse me, working to improve efficiencies there.
I think that's a good segue to talk about some of your recent pieces. So for everybody in the audience, I encourage you to read Dr. Nishtar's pieces in The Lancet that were published in the past few months. One, as it relates to the institutional piece, the Gavi leap, and then this global health leap. So could you tell our audience how you're conceptualizing those two pieces and how that's really part of the future of not just the organization, but how you're thinking about global health?
Well, thank you for that question. So, as I mentioned earlier, when I came 2 years ago, it was quite evident to me that, you know, the context was changing. And I was very conscious that I had to design a reform which would make the organization relevant for a future global health architecture. And therefore, the Gavi Leap was designed as a reform for Gavi. It is predicated on 4 principles: country centricity, country self-reliance, focused mandates for international organizations, and finite lifespans for international organizations. And as part of that, we started recasting ourselves, we started recasting our country operating model, and we started restructuring partnerships. So as far as our internal reform was concerned, there's a whole host of things that we embarked upon immediately. We've downsized our secretariat by 1/3. This is not a haircut. We've done heavy restructuring, creation of new departments, folding of existing departments, modernization of contracts, tighter contracts, better checks and balances, enhanced transparency, digitization of mission-critical processes. These are the internal changes that
I think it's great you're describing it. There's a lot of work that, you know, it's easy to just talk about Gavi Leap, but the operational piece is huge.
It's taken a lot of hours of painstaking work and following up of work plans. These are the kind of things that are not visible externally, but you have to do them in order to be able to do a reform and in order to be able to work on a solid grounding. So that's the one side. The other side was a change in the country operating model. Gavi, as you know, has always been a very impactful organization that countries really value. But in the first 10 days of my taking over, I went to Africa and I asked from heads of states down to health workers. I said, how do you perceive Gavi? How can we improve ourselves? And our reform of the country operating model was based on the learnings from those initial days. And what they told me was very simple. They said, we want you to devolve decision-making to us. We want to make decisions about how to deploy the resources ourselves. We want you to reduce the administrative burden for us. You run far too many grant windows. So the reform at the country operating model was based on those learnings. We've devolved decision making. We used to have 8 grant windows that never closed. There is now 1 grant window, and it's aligned to our grant cycles. These things don't seem very significant, but for a grant-making organization to institutionalize them takes a lot of effort, means a lot of internal changes, and those we've made. For instance, Gavi served on a first-come, first-served principle. Countries could be sending any number of applications, and because there was ample money, we always honored them. But in today's resource-constrained environment, that's not going to be possible. So we gave every country a vaccine budget and said, to a very large extent, they have decision-making discretion on how to use those resources. All these changes required internal planning, looking at evidence, management-level decisions, board-level decisions, execution planning, and consolidated work planning. So all that part was done. Concurrently, we had to, of course, do a reprogramming, because in our replenishment, which in our parlance is the name for fundraising, we were 2 billion short of our target. So we had to recalibrate the program. So that was the third leg of planning ongoing. And then we commissioned several in-depth analyses of partnerships. How do we work with the Global Fund going forward? How do we work better with WHO and UNICEF as we go forward? So all these things were part of the Gavi Leap reform. There were several changes in the stream of AI that we made. So there are a plethora of things under the Gavi Leap reform. Now, what is the global the global health leap, because one is the Gavi leap, the second is the global health leap. And the reason why the second Lancet paper focuses on the global health leap is because we wanted to share our initial lessons with the global community. Because we were making those changes in a context. For those of you who are familiar with how things are moving in global health, every entity, every agency is talking about what the new global health architecture is going to look like. There are papers being commissioned and meetings happening, and donor communities are convening meetings around the new global health architecture. So basically what the second Lancet paper said was that all these lines of thinking it's great, let 1,000 flowers bloom, but at some point we all have to converge, and we have to decide on the principles of the reform of the global health architecture, which is where we put our 4 principles on the table and said, this is how we are reforming, guided by these 4 principles, and we offer to the global community to draw on these as you plan your own principles. Because the principle, there are 2 things that are important when you think about reform of the global health architecture. One is the principles, and the second one is the objective. You see, your starting point has to be what you want to achieve out of the reform of the global health architecture. Do you want to fix things at a country level? Do the donors want to commit less money? Do you want to address fragmentation and duplication? Do you want a balance of the global and regional players? Do you want to enhance competencies that do not exist in the system? Beth and I were at the Munich Security Conference, and there was session after session after session talking about potential AI-related bioterrorism, for which we neither have the capacity nor the understanding within the global health architecture. So basically, the second Lancet paper on the global health leap says, it draws on the previous Lancet paper about the global health leap and says, we need to align on the principles and the objective. And then that should determine the process and what is in scope. Because there is a bevy of institutions out there. There are multilaterals, there are arms of bilateral agencies, there are private foundations, there are over 50 product development partnerships. The list is endless. There is Gavi and the Global Fund. And when you talk about reform, the objective, the scope, what you're trying to achieve, the problem that you're trying to solve, is all dependent on your principles and what you're set out to achieve.
Yeah, thanks. I love that you bring both vision, but a plan and the execution. And I think people are hearing loud and clear that part matters a lot. We're going to open it up to audience questions shortly. I'm going to ask you something that we're having a bit of trouble executing on these days, which is kind of regaining trust in public health. This is something you've thought a lot about, particularly in the vaccine space. What are some strategies that you have found effective, or what are you thinking about in terms of regaining the public's trust? And then we'll open it up to the audience for some questions.
I think it's unfortunate that we're losing trust in some interventions that have been so effective in saving lives. The other day, I visited my ancestral graveyard, and there were so many graves of children. So many graves of children who had died of infectious diseases. I don't think people in countries like the one we're sitting in right now understand that. You haven't seen a child die from diphtheria. You haven't seen a child die as a result of measles. You have no idea how common infectious diseases can kill. I don't think you have any idea how diarrheal diseases can be lethal for children. how pneumonia can be a death sentence for children in a family. And I think we have a collective amnesia. And that collective amnesia is more profound in the Western countries because you have the privilege of having eradicated those diseases. And I think the onus of responsibility is on us to bring reality to bear at this time. And of course, there are structural and systemic causes of why this is happening. Because in today's day and age of social media, controversy, lies, misinformation gets blown out of proportion because there are structural factors promoting that, unfortunately. And those may be beyond the control of people like us sitting in this room, but that doesn't mean we shouldn't call it out. And that notwithstanding, I think we have a collective responsibility to ensure that there's information integrity. And we're trying to do whatever we can, and we're trying to bolster our interventions in this area. But we really have a serious problem here. And this is not limited to the developed world. This is permeated to the developing countries as well.
Yeah, thank you. I mean, it's sobering. Leave us on a note of optimism.
I think that we are in a world which has capabilities that it never has, and I'm very optimistic that if we use the tools and capabilities at our hand, we can deliver a lot. But I do believe from my work back in Pakistan that solutions for people do not come in packages with the names of departments and ministries written on them. When I was rolling out the welfare program for a population of 250 million, the competencies that I drew on were multisectoral. So if it was a cash transfer program for 15 million households, the competencies that I leveraged did not exist within my ministry. I was talking to telecommunication operators and regulators and commercial banks and the national identification system. And it's the way you join the dots to design a system that allows and enables you to execute. And it's the execution discipline that enables you to take plans on a whiteboard to actual reality. I'm very optimistic because we have never had such capabilities that we have today. But we need to think a bit differently, and we need to have execution discipline in order to get things done.
Thank you so much. Join me in a round of applause for Dr. Nishtar. And then apparently we're putting
It's me again.
Craig to work.
That's right. You're going to put me back to work. Thank you both. I really appreciate that. We have 10 or 15 minutes for questions. I am going to come around. If you have a question, we will bring a mic to you. Please just make sure to hold it this close so everyone joining us virtually can hear you as well.
Thank you both for the interesting conversation. I was really interested when you're talking about how when creating institutions, it's really important to be rule-based. And then there has to be a period of execution, but then I would also assume there has to be a period of evaluation. So I'm just wondering how you think about when creating a system and creating rules and executing, when and how do you think about when you should evaluate and maybe change those rules?
Do you want me to answer? Or
Yeah, go right ahead.
I think this is an excellent question because when I put my hat as a former researcher, you execute and then you have an evaluation plan and you have a control group and an intervention group and you design a quasi-experimental analysis and you take a year and you do that. And then your objective is to publish. In real life, that doesn't happen and should not happen. In real life, you should be willing to base your execution on evidence to the extent that you can, but then you should be willing to make adjustments in real time as you execute. I was asked to roll out a very large program when COVID struck. And you basically had to roll out a very large program in an environment of complexity and uncertainty with speed. And you don't have the luxury, excuse me, of saying, I need 3 months to plan. You have to do things on the go, and then you have to be nimble and agile and flexible and humble to be able to make changes as you go along. And I think that is the shift in mindset that implementers need to adopt. I'm not saying there's no space for the classic kind of evaluation. You do them for different kind of endpoints, for impact-related endpoints. But you need to be very agile and embed implementation science into the rubric of your execution.
Thank you. I'll come to you. I'm going to.
So thank you very much for this really exciting conversation. In your comments about saying something positive, you observe that we have technologies, we have systems to do something really new. But to make that sing, to turn that into music requires leadership. Could you reflect on what qualities of personality make for a good leader in this current environment?
In the current environment, I think that one of the key attributes of leadership is integrity. If you compromise on integrity, it's a very slippery slope. And I think that as a leader, you have to have the ability to take calculated risks. So I think integrity and the ability to take calculated risks are the two important things that I think are important. And thirdly, I think humility is very important. And if you are in a technical area, you need to have some subject understanding, because a lot of times I've seen line ministers in ministries who have good intentions, but don't understand the subject through and through to be able to formulate policy and execute. So if you have subject understanding in an area that you're leading, it's a huge plus.
Thank you. We'll shift over here for our next question.
Hello, thank you so much for speaking with us today. My name is Owen, and I had the pleasure of taking a public health course last year discussing pandemic preparedness and biodefense, and we learned all about Gavi and its important role in global health and the supply of vaccines. And I'm a little curious about how, because the US is such a major player in global health, and there have been many recent changes in public health policy in the US given the current administration, how is Gavi navigating those changes, and what more, I guess, needs to be done? Maybe perhaps like what reforms might need to be implemented to also navigate these changes given all the uncertainty in US public health institutions?
So the United States has traditionally been a very strong supporter of Gavi. We have bipartisan support for Gavi on the Hill, as you probably know. There are consistent resolutions in support of Gavi. Year 2025, with bipartisan support, there was a congressional appropriation of $300 million for Gavi. This year again, there is a congressional appropriation for Gavi, and we look forward to the administration executing on that.
Thank you. Dr. Nizzo?
Thank you so much. It's really excellent points that you've shared, a lot to think about. I wonder if I could get your thoughts on something. On Monday, I'll be participating in an event in Washington on science diplomacy. And so I've been thinking a lot about sort of the history of science diplomacy and various different efforts. And one of the things I've been reflecting on is smallpox eradication, which has been described as providing sort of a blueprint for what has become the success of Gavi, or at least some of the impetus and enthusiasm for an expanded program on immunization that helped contribute to Gavi. And I've been struck by, partially because D.A. Henderson, who led the smallpox eradication program, was my mentor, and I miss him very much in this highly contentious times. But I've reflected a lot about what he talked about in the context of when smallpox eradication was launched. It was in the height of the Cold War, and where two powers that were determined to possibly destroy each other saw strategic advantage in vaccine diplomacy and advancing vaccination efforts, and feeling like there are some similarities between then and now, but noticing a clear absence of the focus on that common good, that focusing on the strategic benefits to both nations of those vaccination efforts. I'm wondering, what are your thoughts on vaccine diplomacy, and where do they stand now? Is the hope for that dead, or are there meaningful efforts that countries are pursuing that, even if they disagree on strategic or other political issues, they see mutual benefit in a common purpose on that front?
I mean, we are in a very different context. And as a principle, health diplomacy is something that all countries should see benefit in. But we don't see any tangible examples of that. We do and we don't. I mean, I would say that during COVID, everybody did come together. As far as polio is concerned, which is the second time countries are standing together to eradicate a disease from the face of this planet after smallpox, I don't see a divergence. Even in the United States, where there's a huge amount of vaccine skepticism, there is a commitment to polio, which is a good thing. So I think there are moments, even in this very fractured environment, where countries do tend to come together. But there is definitely huge scope to do more. I mean, we're not even talking about the area of non-communicable diseases, where the cross-border considerations are far more relevant. And there's far more space and scope and potential for countries to come together, to put their weight behind what can truly be called disease diplomacy. And I think in the area of PPPR, there's even more scope. I mean, I referred earlier to the AI-related bioterrorism threats. And these are things that we are not even beginning to understand in terms of their sinister potential. And I think vaccine diplomacy around these new and emerging threats is something that could rally us together, and should.
Thank you. Katie.
Thank you. Thank you so much for coming here and sharing your experiences with us. You had mentioned a couple different times about the importance of being agile, course correcting. I'm thinking that, sort of thinking back to the beginning of the COVID pandemic, I think at least in this country, there was a lot of difficulty to course correct. And I think that's because, everything is so deeply political and entrenched. I'm curious as to whether you can give some more positive examples that you've seen where course correcting really did occur. I'm just thinking about some of the strategies, as we learned more about the infection, how it spread, what worked, what didn't work. There was just very little course correcting here.
Well, during COVID, every country had its own dynamic. You look at this whole space of response to pandemics and response to emergencies from a global lens, and then you look at it from a country lens, and the dynamic is very different. Of course, at a global level, the norms and standards matter. The technical advice matters. The financial instruments that enable access to countermeasures in countries matter. The cross-border collaboration matters. But at a country level, you have to roll out these huge operations. And I recall my time in the cabinet then when COVID had struck. We used to have meetings coordinated by the Prime Minister almost twice a week, cabinet meetings on a single agenda subject. And at those meetings, health was one of the stakeholders on the table, just one of the stakeholders, which I would rather say had a rather peripheral role. There were disaster management agencies, there was military at the table and different wings of the military. There were intelligence services providing information and data. There were cell phone operators. Initially, because our infection came from certain routes, it was the cell phone operators who gave us data from the towers to explain how the infection had spread. It is aviation, and it is the border control agencies. It is a whole host of agencies. It is the local governments, it is the provincial governments who have to open their service delivery points. It's the whole machinery of the government at the three levels that had to be put into play. And there were the fiscal considerations of it, and how the central bank had to weigh in and all that. So I'm going from your question a little peripherally to answer that. And there was course correction every step of the way. You do a blockade, and you impose a lockdown, and then you learn from how it is played out, and you kind of change the policy. So to the extent of how I experienced COVID, at a country level, I saw course correction play out every step of the way. And in fact, because I was responsible for the cash transfers at that time, in the book that I subsequently wrote, which is called Delivering Welfare at Scale, there's a chapter on the cash transfers in which I explained how the course correction happened. I mean, to cite examples, I recall the first day when the intervention was rolled out, and I went into a camp where there were daily wage workers. Life for them had come to a standstill. They could not go back to their villages because there was a lockdown, and they could not find jobs because the economy had all closed. And we had a campaign which was called 8171. The name of the campaign and the number was because I was asking them to send their identity card numbers on that SMS short code, because that allowed us to plow that into the wealth profiling system to ascertain their eligibility, subsequent to which their identity card numbers would go to commercial banks where they'd draw their money. So the first day I go on national television, I announce, and then I go to a camp where there were about 50 laborers, and I say, how many of you have heard about 8171? Everybody raised their hand. How many of you have sent SMS messages? And only half of them raised their hand. And then later on, one of the laborers came and whispered in my ear, I don't know how to send an SMS message. I only know the red button and the green button. The red is to stop the call, and the green button is to. And it was so humbling. And then we immediately went to the television, and I said, we need a volunteer force to come forward and send the SMSs from their cell phones and educate them how to do that. I'm just giving you some very practical examples. The next day, because there was an algorithm through which the person receiving the stipend in a family would have to be identified. So it would hit an algorithm in the system. And I was on national hookup, national radio, and a woman, and I would take live calls to explain to them as they were having problems. And a woman called and said, I received a message that your father has to go and receive the money on the family's behalf. What kind of system have you set up? My father died 3 years ago. And I had to explain to that woman on national television, said, is your father's death registered? She said, no. I said, then my system has no way of knowing that your father has died. So many of you will receive messages for dead beneficiaries in the family to pick up the money. And if that is the case, this is what you do. And I explained the system. So perhaps I'm going too granular, but I'm explaining to you that in emergencies, in, where you have to execute at scale with speed and in an uncertain environment with a system that you've just set up, you have to be very humble, and you have to be very humble and nimble, and you have to be very open to making mistakes and correcting them. And I'm sure that happened at every step of the way, and it must have happened in every country.
Thank you, Dr. Nishtar. We're nearing the end. I want to make space for one more question, and then I'm going to briefly and selflessly ask you for a closing comment, if you don't mind.
Thank you again for your comments. I wanted to build off the last question about the pandemic and your assessment at Gavi in terms of how we did as a world in terms of delivering the coronavirus or COVID-19 vaccine to lower and middle income countries. And as we invariably await the next pandemic, how could we do it differently in terms of hopefully having a vaccine for the next pandemic?
So wearing my Gavi hat, I was not there at Gavi then, but I think putting together a financial instrument with speed, engaging at least 70 other countries that you've had no relationship with, taking the risks that Gavi did at that time for wider interest. I think these were enormously important things for Gavi to have done. Of course, things are not perfect, and Gavi came under heavy criticism because of certain shortcomings. But I think they were very courageous in doing whatever they did, and I think that it played a huge role in providing access. But I want to go back to your question about the lessons learned and the course correction, because from that experience, there were two very important things which helped course correct for the future. One of them was the First Response Fund, because the learning from that time was that there wasn't money, liquidity available at day zero. So my predecessor and the teams there, and Pascal, who's here with me, was part of that team, went around fundraising. Our resource mobilization department had to fundraise. Learning from that, we put in place the First Response Fund, the Day Zero financing facility. So when MPOX struck, within 3 days of the pre-qualification of the vaccine, we were speaking to the manufacturer. We had ordered 500,000 doses, which were then shipped to DR Congo and the other countries. So that was the one course correction, that wholesale course correction that we did. The other one was related to Africa, because Africa was at the back of the line during the COVID pandemic, and that clearly should not have happened. And learning from that, Gavi put in place the African Vaccine Manufacturing Accelerator. This is a subsidy mechanism to promote vaccine manufacturing on the continent. Now, again, back to your question about course correction. When I took over, the African Vaccine Manufacturing Accelerator had already been structured as a subsidy instrument. And we went back to the continent, and we've had 3 forums on the African continent since then, since I came in. to learn from stakeholders, are they happy with the subsidy instrument? How does that play into their needs? And what we learned from them was that it's insufficient. They want upstream help. They want capex injections. They want demand guarantees. So we went back to the drawing board to course correct. And we've structured now what is called AVMA Plus. And in fact, day before yesterday at the One Health Summit in Lyon, I announced that we will be taking another financial instrument to our board in July, on which the management has already aligned, to be able to provide them with the support that they need. So these are two examples. I'm joining the dots between your two questions. These are two examples of how we've learned from the shortcomings and from the issues that emerged, and how we've course corrected through two financial instruments which deliver at scale.
Thank you, Dr. Nishtar. And as we close and move to the reception, I just wonder if you could share a message that we could share with our own communities, a message that you might have to the people of the US about why Gavi is important and why we should be supporting you at a time of, as you noted, increasing vaccine skepticism of a global health apparatus. What is the message that you would like us to share with our friends, our families, and our communities?
So to the US, I think the US should be very proud that the US was part of Gavi's creation, that the US has consistently supported Gavi over the last 2.5 decades. And I think Gavi really matters for the US because in the pandemic prevention and response system at the global level, different entities have different roles to play. And Gavi has been vested with a very important mandate, which is to maintain the stockpiles and to be the custodian of the first response financing mechanism and the Day Zero financing facility. And the US actually did partner with us in the past by providing liquidity arrangements to further enhance these capabilities through the DFC. And these capabilities, the stockpiles, the Day Zero financing, is not just for developing countries, it's for all countries of the world. To give you an example, when Ebola struck, and Craig, which you were part of that and witnessed it firsthand, all hell had broken loose at that time. The disease was on different continents within a matter of days and weeks. But when there were Ebola outbreaks a few months ago, nobody heard about it. Why? Because investments were made on the vaccine, and the stockpile existed and the vaccines were mobilized. So the United States administration and the people have to understand that these capabilities that your governments have vested in us are for a reason, and it is for your protection, and it is to prevent diseases like Ebola from coming to your soil. That is the one reason why Gavi is important. The second reason why Gavi is important is because we work in 44 countries of Africa. And 80% of our resources from January 2026 going onwards will be for Africa. And of course, we take your goodwill and your resources to where they're needed the most through instruments that you have created. The third reason is malaria, of course. The new malaria vaccine, there's a huge demand for the malaria vaccine in Africa. And because of our funding constraints, we've had to downsize the program. Every head of state in Africa is asking, because there are 25 countries that have already rolled out the malaria vaccine. Each one of them is asking that we find them the money to be able to continue to the program on its intended scale. The United States can show it deeply cares about saving lives, malaria-related lives, and we are a vehicle through which that can be achieved. Another reason is purely commercial. We bring American vaccines to the world. We purchase from American vaccine manufacturers far more than what the US gives us in contributions. So it makes good commercial sense to contribute to Gavi. So for all these reasons, and of course the most important thing is that vaccines save lives. Vaccines save lives. Let this message sink in. If it wasn't for vaccines, graveyards would be full of small graves. It's deeply disturbing to watch that. We don't want to go back to those times. So I think academic institutions like yours and the powerful voices that you have, the powerful voices that policymakers trust, should be able to carry this message back to your policymakers. We want to work with your country and with your administration, and we would like for the support to be continued for the sake of the world's children and for the sake of the security of your people.
Thank you. Thank you very much.